అది నేను అప్డేట్ చేసి పంపించాను మీకు.
I just want to focus on the basic epidemiological concepts. In the corner of that slide, you will see a few questions. Yeah, what, who, how, when, where, why. We say these are the fundamental questions whenever we discuss any health problem, any disease problem. We start with what is the problem. We say, okay, where is this problem? In whom is this problem? When is this problem occurring? Why is this problem occurring? So these questions, these are also called the famous 6 horsemen. So each of them, you ask one question. In order to answer these questions, once you have the answers, then that gives you what is called epidemiology, basically to try and find out the distribution, how diseases are distributed, and determinants, what are the causes for these diseases. Now, for a long time in the history of public health, we believe that diseases were either due to bacteria or due to virus or due to a parasite, what was called a germ theory. But later on, the single germ theory yielded to what's called the epidemiological triad. So you can see on the screen this picture where I'm showing you the agent, host, and environment. So basically, the agent, host, environment are the factors that we consider whenever we look at any health problem or whenever we look at any health problem. So normally we expect that any disease results from an interaction between the agent, host, and the environment. And so the idea is, disease doesn't occur only because there is a bacteria or there is a parasite. It also occurs because the human host is susceptible to that disease. And it also occurs because the environment in which the agent is floating around, is present, that also has to be conducive. So basically we look at agent, host, and environment in order to understand epidemiology of any disease. And the next picture that I have there for you on your screen there, so it shows you what is called the natural history of disease. So every one of us, when a disease, bacteria or virus enters into our body, there is a stage of susceptibility. Here, we are susceptible. The bacteria or virus has not, entered us, but we are at risk. And then there is this stage of exposure. We are exposed. Like today, we talk about exposure to a COVID organism. And then, we have some pathological changes happening, but these are called subclinical because these symptoms, signs of that disease are not appearing. Then there is a stage where the symptoms start, what's called the onset of symptoms. That's when we go into what is called the stage of the clinical disease. And usually, even after the symptoms begin, there's a small gap before we diagnose any disease. So that gap also means that even though your symptoms have started, we don't immediately diagnose on the first day of your symptoms. Sometimes the patients take their own time to approach a doctor, or the doctor also is not very sure what investigations to carry out. He says, let's observe you for a day or two. So then the clinical disease progresses, and then, later on, depending upon whether the patient is treated, not treated, depending upon his immune status, there's a stage of recovery, or sometimes for certain diseases, they go into what is called disability, or sometimes the patient dies. So this is what's called the natural history of disease. The reason why we should know the natural history of the disease is because, the natural history of the disease will guide you in trying to determine whether we what stage a particular disease is, when we can diagnose it, and when we can start looking at the problem as a public health problem. So in the case of COVID, symptoms appear about 2 to 14 days after exposure. The average incubation period, we say incubation period is the time between your exposure to your appearance of signs and symptoms. The average is usually 5 days. About 80% of the confirmed patients have actually mild symptoms. In very severe diseases, severe cases, patients develop pneumonia in both the lungs, and in some cases COVID can also be fatal, as we are seeing. Now, because the spectrum of disease, this natural history also shows you there is a spectrum of disease which can include asymptomatic cases, that means no signs and symptoms, or we can have mild cases. The cases of illness diagnosed by clinicians in the community, they often only represent the tip of the iceberg, as you can see in this third picture that I have here. So very often we only see people who have died or people who have been hospitalized. Sometimes we do find out that general practitioners are diagnosing and treating. Sometimes people are self-reporting, and sometimes we detect cases only when we do population screening. Right now, what's happening in the case of COVID-19, that you screen people, what's called contact tracing, all those who have been in contact with a particular patient, we screen and try to find out. So that's how the more of the iceberg that's hidden that you are able to detect, the better it is. So from a preventive point of view, from a public health point of view, we should just not be satisfied with seeing the tip of the iceberg. Tip of the iceberg is relatively easy to see. We try and find out as much of the hidden iceberg as possible in order to institute preventive measures, in order to institute any large-scale public health interventions. Now, in COVID-19, we hear the word super spreader. So as you can see in this picture, commonly infections, they spread from person to person through whatever media, through airborne transmission, through waterborne transmission, and so on. But in a super spreader, the one person can spread not just to 2 or 3 like you have seen in this picture, but one person can spread simultaneously to a number of people. And this is what's causing today the COVID-19 problem in such a big way. So if you want to know some of the recent super spreader cases, we found that in 2003, in Hong Kong, there was a doctor with SARS virus. He died, but he spread the disease to more than 100 people. In 2015, we had the MERS, Middle East syndrome, as we say, respiratory syndrome. We had a patient in South Korea who died, but before he died, he spread the disease to 82 people. And when we come to the COVID-19, one of the first persons was a British man who caught COVID in Singapore. He recovered, but before recovering, he spread to 11 people. Subsequently, we found that the patient number 31 in South Korea, he was linked to about 70 cases in February. So you can imagine, subsequently, we have had many more super spreaders. We have had Baldev Singh in Punjab, who spread to more than 80 to 100 people. We had the Tablighi group which met in Delhi, and this was a group which met from all over the world, and they went around spreading to so many people that one of the super spreader group, in fact, in India today, whatever we discuss about Indian situation later, they also have contributed in their own little way. But the super spreader can spread virus without sometimes exhibiting any symptoms. That's the point to note. Then let's, this table here just summarizes, we have had more than 20 pandemics over time. Some of the earliest pandemics actually began thousands of years before Christ. I'll talk about them a little while later. But some of the prominent ones, how they have occurred, the time period 165 to 180 AD and so on, and up to the present COVID-19. Also the type in terms of whether it was caused by a bacteria or a virus, whether there's a pre-human host before it affects the human being, also the death toll. So this picture just summarizes the major pandemics over time. We'll talk about a few of these pandemics very briefly. So as I said, 3000 BC, in fact, that means it's a 5,000-year-old house, was found in a place called Hani Manga in China. And they found in this house, there were 100 skeletons of all ages. That means must have been a huge gathering there of people. And they all probably died of a deadly epidemic. In 430 BC, not long after the war between Athens and Sparta in Greece, there was an epidemic that ravaged the people of Athens, and it lasted for 5 years, killing in those days 100,000 people. It was believed that overcrowding caused by the war exacerbated the mysterious epidemic, which could have been typhoid, Ebola, or some other disease. We are not sure what exactly it was. Then we come to 165, 180 AD, when we had what is called Antonine Plague. People believe it could have been smallpox, and it was first brought into the Roman Empire by soldiers returning home after a war against Parthia, which killed more than 5 million people those days. Then we had the plague of Cyprian, Saint Cyprian of Tunisia. He described the epidemic as signaling the end of the world. You see, every time you have a pandemic, people get scared and they predict it's the doomsday, the end of the world. This epidemic is supposed to have killed about 5,000 people a day in Rome alone. A mass burial site of plague victims covered with a thick layer of lime, which was used as a disinfectant those days, as well as 3 lime kilns were discovered by archaeologists. Then we move to what's called the plague of, Justinian. And this was actually a bubonic plague. It ravaged the Byzantine Empire under Emperor Justinian. It decimated the whole empire and killed up to 10% of the world's population in 341-542 period. Then we have the Black Death, which occurred in 1346-1353. The Black Death actually traveled from Asia to Europe. It wiped out over half of Europe's population, changing its history, leading to technological innovation. It was caused by what's called Yersinia pestis bacteria, and it was spread by fleas on infected rats. Then we had a Cocolizid epidemic, which was in 1545-1548. And it's a form of viral hemorrhagic fever that killed 15 million inhabitants in Mexico and also Central America, who were already weakened by extreme drought. Then we moved to the 16th century when we had the American plagues. A cluster of Eurasian diseases, including smallpox, were brought to the Americas by European explorers and contributed to the collapse of the Inca and Aztec civilizations. 90% of the indigenous population was killed off in those days, both by war, but also by these diseases, including smallpox. Then we moved to London, 1665-1666. As we said, that Black Death actually continued to recur. It was plague which kept recurring. The Black Death's last major outbreak in Britain caused a mass exodus from London. It was led by King Charles II. 100,000 people, including 15% of London, died. And London's woes did not end. There was a fire that broke out on 2nd September and burned down a large part of the city. We moved to the Great Plague of Marseille in 1720-1723 in France. There was a ship called Grand Saint Antoine, which was docked in Marseille, France, carrying a cargo of food, goods from the Eastern Mediterranean. The ship was quarantined, but still plague got into the city, and it killed around 100,000 people in and around the city. Then we have the Russian plague, which occurred between 1770-72. In plague-ravaged Moscow, 100,000 died. The terror of quarantined citizens erupted into violence and riots throughout the city. So riots did happen hundreds of years back. Empress Catherine the Great, who was the Empress of Russia those days, she issued a hasty decree ordering that all factories be moved out of Moscow. Then we moved to the USA. Philadelphia, as you know, was the capital at that time in 1793. Yellow fever seized Philadelphia. Officials then wrongly believed that slaves were immune and people of African origin were recruited to nurse the sick. The epidemic finally stopped when winter arrived and more than 50,000 had died. Flu pandemic of 1889-1890 in the modern industrial age, new transport links made it easier for influenza to spread from Russia to throughout Europe and the rest of the world. In just a few months, the disease killed 1 million people. The American polio epidemic in 1916, it was a polio epidemic that started in New York City, caused 27,000 cases and 6,000 deaths in the US. The Spanish flu in 1918-1920, an estimated 500 million people from the South Seas to the North Pole fell victim to the Spanish flu, and 20% of those died, while some indigenous communities became extinct. The cramped conditions of soldiers and poor wartime nutrition during World War I enhanced the lethality of the virus. Then we moved to 1957-58. With its roots in China, the Asian flu disease caused by a blend of avian flu viruses spread rapidly to Singapore, Hong Kong, and the coastal cities of the US. More than 1.1 million died worldwide, with just 116,000 deaths occurring in the US itself. The 17th major pandemic that the world has seen is still ongoing from 1981. It's the AIDS pandemic. AIDS has killed around 35 million since it was first identified. HIV likely developed from a chimpanzee virus that transferred to humans in West Africa in the 1920s. AIDS was a pandemic by late 20th century. Then the next major epidemic was the H1N1 swine flu pandemic, which occurred between 2009 to 2010. The 2009 swine flu pandemic was caused by a new strain of H1N1 that originated in Mexico before spreading to the rest of the world and infecting 1.4 billion people, killing between 151,700 to almost 575,400 people. That's the estimate. A vaccine for the H1N1 virus that causes swine flu is now included in the annual flu vaccine. Many of you who are in the US know that you take annual flu shots, and this is part of that flu shot. West African Ebola epidemic in 2014 to 2016. Ebola ravaged West Africa between 2014 and 16, with 28,600 cases reported and 11,325 deaths. It started in the country called Guinea in December 2013, quickly spread to Liberia and Sierra Leone. A few cases occurred in Nigeria, Mali, Senegal, US, and Europe. As such, there's no cure for Ebola. Vaccine efforts are still ongoing. Ebola first occurred in Sudan and the DRC Congo in 1976. Virus may have originated in bats, something common with COVID-19. Then we move to the Zika virus epidemic, 2015 to present day. The impact of the recent Zika epidemic in South and Central America won't be known for several years. Scientists face a race against time to bring the virus under control. It's usually spread through Aedes mosquitoes, although it can also be sexually transmitted to humans. While it's usually not harmful to adults or children, it can attack infants who are still in the womb and can cause birth defects. Now, some of the key lessons that we learned from the past pandemics. Diseases have ravaged humanity since antiquity, changed the course of history, and even ended entire civilizations. Diseases have killed more humans in history than any other cause. Belief that diseases resulted from the wrath of gods led to disastrous responses and deaths of thousands, if not millions, of human beings. Pandemics are a breeding ground for conspiracy theories. Even during the Black Death, Jews were scapegoated and suspected to violent attacks and massacres across Europe. During the 2015-16 Zika virus outbreak, the virus was considered a biological weapon. From arguments about masks to riots outside hospitals, history repeated itself in the form of human responses. The more civilized humans became, the greater the occurrence of pandemics. Quarantine as an intervention started in the 14th century, and it continues to be practiced till date, including in COVID-19. Death rate reduced over time, mainly due to medical advances, such as vaccination and antibiotics, and also improvements brought about in the urban environment. Medical advances, however, are unlikely to even ever offer full protection from a possible pandemic because of the novel nature of the diseases involved and made worse by environmental degradation, livestock, and overpopulation. New infectious diseases like SARS, HIV, Ebola, MERS, they've all increased by nearly fourfold over the past century. Now, remember, I was telling you COVID-19 pandemic was not totally unpredicted. We knew a pandemic like COVID-19 would occur. Many of you must have heard of Nostradamus, a famous French physician, astrologer, seer who predicted a coronavirus-like disease. You must have seen this 1981 novel going around, The Eyes of Darkness, authored by Dean Koontz. And in fact, it's surprising that the virus in this novel was called Wuhan 400, a biological weapon with 100% mortality rate. Thank God COVID is not that fatal. Infectious disease expert Michael Osterholm wrote in 2005 that time is running out to prepare for the next pandemic. In his 2008 book, Global Catastrophes and Trends, Václav Smil, he wrote that the US and world are highly vulnerable to another viral pandemic. Then there is this film of 2011, some of you may have seen it. It's about a fictional illness called MEB1, which becomes a global pandemic after a bat spread it to a pig, who spread it to a person who then didn't wash his hands before shaking hands with another person. In his 2015 TED Talk, Bill Gates said, the world was not ready for the next epidemic. He warned President Donald Trump about the dangers of a pandemic way back in December 2016. Like many other things, Donald Trump didn't care two hoots. Virologist and flu expert Robert G. Webster predicted in his 2019 December book, Flu Hunter, Unlocking the Secrets of a Virus, an upcoming flu pandemic, that another deadly disruptive pandemic is possible. He warned and suggested what we need to be prepared. He said this in December, the very time the epidemic was breaking out in Wuhan in China. So, are we all at equal risk? In the health policy world, we often use the phrase, diseases know no borders. And COVID-19 can attest to this. You know, today more than 200 countries have been affected by COVID. The virus spread through inevitable consequences of globalization from Asia to Europe and beyond at a rapid pace. The virus does not discriminate. We are all equally at risk. However, that's not 100% true. There are examples from around the world showing that certain segments of society disproportionately suffer from SARS-CoV-2 virus and its wider socio-economic impacts. In USA, they have seen African Americans in many US cities who are becoming infected with the virus and dying from COVID-19. At many times, their representation in the population. Similar statistics have been observed in Norway and the UK. Other marginalized groups who are disproportionately vulnerable during this pandemic include those based on employment status, income levels, political exclusions, access to healthcare, comorbidities, disabilities, religious affiliations, sexual orientation, housing status, immigration status, These are all many factors that have to be studied in more depth to understand how this disease is actually affecting certain segments of the population more than others. Now, what's the most effective strategy to control COVID-19? You know, if you see this curve in this picture that you have here, normally when there's a pandemic and there's no intervention, the disease runs its own course, and then there's a peak, and then slowly, as number of days or number of months pass, the number of cases come down. Now, the idea, if you see, there is this reduced curve that I'm showing you in the picture here. The idea is we want to reduce the peak number of cases, and because when you have the peak number of cases, there's a demand on hospitals, on infrastructure. And then, we would like to reduce the number of overall cases and the health effects. So the idea is to what's called flatten the curve. We use the term flatten the curve. Instead of having a peak, we try to flatten the curve. And that flattening can only happen through certain interventions. And this picture at the bottom here tries to show you that where India stands in terms of health infrastructure. Many people have criticized why India has gone for a lockdown. One of the reasons that they had to go for a lockdown is because we are at the bottom of, in terms of health infrastructure, whether be it the number of beds per thousand population or the number of doctors. When we compare to other countries, we are really at the rock bottom, and we needed to do that. So what's an aggressive approach to control COVID-19? I think it's these 5 major, strategies, or 5 pronged attack on COVID. An aggressive approach would include social distancing. Many of you know what social distancing is. Contact tracing. So every case that you find, every positive, you try to dig deep into all the contacts and the contacts of those contacts, and you try to find out and test them, whether they are positive. Then testing is also an important part of this strategy. Isolation. There are 2 terms we use. Isolation. We isolate those who are, positive. But those who are not positive, but they have come in contact with a COVID patient, we use the term quarantine. So quarantine, we normally say for 14 days because that's the maximum incubation period we think. Of course, COVID-19 can also transmit beyond 14 days, but the usual period that we take into consideration from a public health perspective is 14 days. So we quarantine people for 14 days if they come in contact with somebody who's positive.
Seshu,
Then of course treatment.
Seshu, just you asked me to caution you on time. I think we have another 15 minutes.
Okay then, yeah. All right, I'll try to speed up and focus a little more. Thank you so much, Swara. So there are also 9 essential approaches to crush the curve, getting everyone on board, protecting the essential services, making sure we have lockdowns, widespread testing, quarantine, health guidelines, wearing masks, supporting medical care, travel restrictions. So some of these. Then there's also the rationale for quarantine and lockdown. So basically, we can consider people into 4 groups, A, B, C, D, as you can see on the picture. So A is the first case, what we call the index case or carrier. Then A are the first to fall sick and they are under treatment. A goes out to meet C, but passerby B is in the public. A and B do not know each other. So as A goes to the airports, bus stations, wherever to meet C, there's also B, and who A and B don't know each other, but B can get the disease from A. So whatever the number, it's easy. Sorry. So it's easy to find C and put them in quarantine. D is expected to stay at home. So They don't go out. They're not much a problem. The problem is with B. We can't find B, and no one knows who is B themselves. And even bigger problem is when D goes outside, D who is at home after the lockdown or in order to get some essentials, goes out in contact with B, and then as a result, D now becomes the new B or called B2. So the whole issue here is, why we do quarantine, why we do lockdown, is try to minimize the contact of A with B and thereby reduce B2. So I'll skip this slide. And the next slide is about herd immunity. People have been talking about herd immunity. It's an ideal if we have 70% or more of the people with immune status, either because they have suffered from the disease or they got a vaccine, then the rest of the people, the remaining 30 also get protected. That's what's called herd immunity. However, despite more than 4.3 million confirmed cases worldwide, no country is even approaching the levels of immunity needed to collectively slow transmissions. Even in Wuhan, China, only 2 to 3% had developed antibodies. In Spain, about 5% of the roughly 90,000 people tested were positive for antibodies. Even in the hard-hit New York City, preliminary testing of 1,300 people found that only 21.2% were positive for antibodies. Nearly 80% are still susceptible. Sweden has been hailed as a model. My niece is one of the listeners here, and she stays in Sweden. Sweden has been hailed as a model for how to operate without strict social distancing measures and build herd immunity. Sweden notably didn't enact official lockdowns and kept schools open for students under 16. And Sweden's response has come with a heavy human toll, highest per capita mortality rate in Europe. Only 1/3 of Stockholm's 1 million residents may have been exposed to the virus by early May, with no idea how long immunity could last. With herd immunity or effective treatments and in the absence of social distance, without herd immunity or effective treatments, in the absence of social distancing measures, countries will need to prepare for periodic and unpredictable spikes of new infections until a vaccine is widely available. Countries that have done well, South Korea managed to slow the spread without instituting any lockdowns because they did what's called mass diagnostic testing. And South Korea has really, followed this by doing more than 51 million tests, and more than 20,000 people are tested there. Canada is another country. They managed to roll out more expansive testing than the neighboring USA. And, Canada has a well-funded healthcare system, one of the best in the world. And by catching cases early, investigating their origins, Canada has really blunted the impact of the virus thus far. Taiwan is another good example. Remember, it's just 100 miles away from mainland China. But they have managed to keep their numbers confirmed to just 441 with 7 deaths as of 27 May. Taiwan appears to have limited its spread. And one of the reasons is they learned their lessons from SARS outbreak, and they began inspecting travelers coming from Wuhan. On 31st December itself, they imposed a 14-day quarantine requirement for all arrivals. They harnessed technology to trace and isolate sick people. They focused on hospitals and monitoring movements there. They also closed all entertainment venues and some educational institutions. They trained communities for lockdown through large-scale simulations. But also the public, they have a very cautious approach, and they started wearing face masks. Most public activities are still open, but people have been very careful. They follow social distancing. Restaurants and malls are open, but there are very few visitors. The greatest concern in Sweden has been deaths. Sweden has imposed no lockdown. Their policy initially paid off, but from April, cases began to accelerate. Sweden's population is double that of Norway, but they have 4 times as many cases. With almost 4,000 deaths, Sweden has the 6th highest per capita death rate from COVID. But over the last 7 days, with 342 deaths, Sweden has the highest per capita daily death rate in the world of 5 per million. So that's another curious case. India's COVID situation, as you know, it's blowing up. This is the all India picture. we have, I think, off late more than 165,000 cases, but this is data that I was able to capture. Some of the major states, Maharashtra, Gujarat, Delhi, and Tamil Nadu, they contribute to majority of the cases. One of the states that did admirably well in India is Kerala. They were able to flatten the epidemic, although recently they have had a recent spurt of cases. I'll skip some of these because I'm sure you have been seeing these in your social media, in your newspapers. But what India right now, what is peculiar about India? We have the lowest case mortality. That's true. Even at this point in time, our case mortality is 0.2 as compared to China, which had 0.3. And then when you look at others in this picture here, you have UK with 52.1, Italy with 52 point. These are all per lakh population. So you have Belgium, which had a very high, COVID mortality of, let's say 79.3 and so on. So at the moment, our mortality rate is low, but we have entered the 10 worst affected countries. After Brazil, our daily cases of coronavirus are growing at the fastest rate. Since April 27, there has not been a day when India has posted fewer than 1,500 cases. And I think in the last few days, we are seeing more than 7,000 cases a day. Our response, we had good planning, good execution. It was a proactive planning execution. We also had surveillance at the country's points of entry, public communication, ensuring safety of Indians abroad. World's biggest lockdown, 4 phases, our latest phase ending on 31 May, and tried to ensure continuity of essential medical services, essential services. But the major, problem has been with migrant laborers. We have seen so many stories on the social media, very heart-rending scenes. But then, the government said we have some social packages, economic packages, also some international partnerships, including with SAARC countries. Definitely, the coronavirus infections have slowed down during the lockdown. As you can see, what's called the 7-day R0, what we call. So the R0 has come down, but in the pace of coming down has slowed in recent times. So as India contemplates opening up its economy, one argument that supports the strategy of a gradual release from lockdown is that the country's young demographic profile will act as a protective shield. However, with the impending monsoon, challenges are only going to mount. Mid-course corrections may be required to stem the further rot. We have also seen, COVID has had an economic impact, major economic impact. There are several scenarios that IMF and others have drawn up. We need to have a phased exit. I'm sure everybody is going to listen in tomorrow when the Prime Minister of the country in India is going to talk about the blueprint for the next stage of the graded exit plan. But one of the things is, many of us in this group today, we are in the high-risk groups. We are the elderly citizens, the education sector. Some of them, probably the lockdown has to be extended for them. But, removing lockdown for common citizens, workforce, agriculture, laborer, and so on. I think these are some of the things that may be announced. And partial removing lockdown for manufacturing sector, e-commerce, domestic air travel, trains, metro, all this. More announcements, I'm sure, are coming tomorrow. Our program, I will leave this slide just to tell you that we have seen lots of strengths in India's program, but there are also a number of weaknesses. And some of the key lessons, I'll again, because of paucity of time, but one thing I can promise you, you will get the detailed slide set through Mr. Subbarao that we shared to every one of you. And the detailed slide set will give you more details than what I've been able to express so far. One of the important things in COVID-19, speed is important. You have to move very, very fast. We know what can contain COVID-19. At least we don't know too well about COVID-19, 5 months into the pandemic, but still we know how to contain it. The important thing is, the hard part is how to implement what we know. What works, we know, but implementation. We have seen in India also, we have had lockdown, but so many people were breaking the lockdown there. Civil liberties face their greatest test. Many countries hesitated to put lockdowns because they thought, UK and other countries were hesitating in Europe. And today we have, digital surveillance tools are being used. There's always the possibility that after the COVID-19 is over, what's justified today may become a normalized one tomorrow. The public trust has to be put under strain because, one of the important things is, the public trust for the epidemic to be under control. Leaders who deny science are a liability. We have seen this happening in Brazil. We have seen this happening in US. When you deny science, we have seen this happening in Andhra Pradesh. We have seen this happening in Telangana. So where leaders have made fools of themselves. Yeah. Self-sufficiency matters again. I think this is one area where India has recognized that we need to be self-sufficient. Taiwan was one of the first countries to realize self-sufficiency, and we have learned our lesson. Global cooperation is absolutely essential for COVID-19 control. Austerity and inequality make us less resilient. So this is another thing that we have realized. How will we live with the virus? How do we adapt to the new normal? People will have to adapt. Life will change. Social distancing may be relaxed only if people wear masks in open spaces such as on trains and at work. We'll have to get used to extensive monitoring. Health authorities will need to identify people who are potentially infected. Testing and contact tracing will be increased to mitigate some of the risks of transmission. People must play their part too by maintaining hand washing, physical distancing, and avoiding gatherings, particularly in enclosed spaces. At restaurants, tables will have to be shielded from each other. Serving staff will have to follow strict rules to prevent spreading the virus. Repurposed drugs are faster to test than vaccines, so we may have an antiviral or an antibody treatment that works before a vaccine is available. Immediate treatment when symptoms come on could at least reduce the death rate. It's difficult to predict the destiny of this virus. Will it continue to circulate after the current pandemic? Or will it, like some of the pandemic viruses in the past, disappear or become less virulent? That we really don't know at this point in time. Our homes will change after the pandemic. Small independent houses, disinfectant zones, smart working spaces, smart air and water filters, hyper-free responsible crops and gardening, local producers will become kings. We might even go in for bunkering, like wartime, we might have to go for bunkers. So I know, the time is too short, but I've tried to capture some of the lessons. But I think this is an opportunity for people to ask questions. So I'll stop sharing at this stage, pause, and allow people to ask questions.
Thanks, Seshu. That was really, really nice and very concise. Well said. So I have some questions here. So everybody, please type in your questions into the chat box. I'll try to consolidate, 2 or 3 so that we can save some time. I see another classmate of ours, Professor Narasimha Rao. He is from the Indian Institute of Science. He has joined us from Bangalore. Welcome. I'm sorry I missed you earlier. Maybe I didn't notice. So Seshu, the first question is, there are 2 schools of thought about this lockdown. You covered a part of it. There are very vociferous critics that, our Prime Minister has been a fool to shut down the economy. It will take us several decades to recover. Is one strong group, and others, of course, like you, public health experts, say that is the only sane way to flatten the curve. Where does the truth lie?
Yeah. Okay. In my view, are you able to listen? Yeah.
Yes, yes.
Yeah. You know, social distancing, lockdowns, these are only temporary measures. These cannot be long lasting. As I've shown you through a couple of graphs, we need to flatten the curve because, especially in developing countries like India, we just don't have our health services being in a position to cope with the large amount of cases that we have. You know, our hospitals, if we hadn't put this lockdown in India, I'm sure we would have had several times more, despite the lockdown, because of people's behavior, where they did not comply with the lockdown rules. They were even willing to be beaten by going out into the streets by the police. Of course, it was pathetic to see that happening. But nevertheless, this, in my view, as a public health expert, I feel a lockdown was a must, but then we also know that a lockdown cannot go on forever. And fortunately for us in India, you know, with the death rate being so low, that does give us, you know, what can I say, an encouragement to, you know, go in for a phased lifting of the lockdown.
Thank you. The other popular questions seem to be relating to vaccines. So the questions are, what is a realistic estimate of when a vaccine could be commercially available for the general public? And in the more immediate time frame, can you comment on the efficacy of
Widow?
Can you comment on how effective is the mask? Is it really necessary? Again, there are two schools. I'm trying to consolidate. There are several questions, but could you speak to these two, vaccine and mask?
Yeah. Okay. Let me share a couple of slides I have, which will make it easy to explain. Is that okay?
Sure. Please share your screen.
Just give me a second.
Yeah.
They seem to have frozen out. 1 second.
So while Dr. Seshu is trying to find the slide, if you have questions, please type it in the chat box.
Oh yeah. Okay. I forgot to press share. That's
Right.
what was happening. Yeah.
Right.
Okay. That's why I was wondering why nothing was moving. Just give me a second.
Sure.
I'll find my slides on vaccines.
Can you hear me, Seshu?
Yeah. Very much. Okay. Let's look at my slide here. I'm sharing the slide.
Yeah.
Okay. So, you know, we have today a number of vaccine candidates. WHO has actually published what's called a vaccine landscape. There are 8 candidate vaccines in clinical evaluation. 110 candidates are in what is called preclinical evaluation. And it's hoped that at least one will work safely out of all these 118 candidates that we have. But please remember, they're all in an early experimental phase. It may take more than a year to prove their work and another 6 months after that to manufacture and distribute them. You might see in the social media, you know, oh, we'll have a vaccine in September, we'll have a vaccine in January, but it's, you know, unlikely that any one of them will really be available. Also, what works at this stage may not work in the real situation. What I mean by that is today, if you are trying your vaccine in people who are young volunteers, but your target tomorrow may be the older 60 plus, 65 plus. And you know what works in a younger individual as a vaccine may not work in an older individual. So that's the other risk that we take, that even if we have a vaccine, one of these vaccines work, and you know it may still take a long time. But anyhow, two vaccines are actually in an advanced stage. One is produced by the company called Moderna. It's called mRNA, and you know they're going in for a phase 3 clinical trial in July, and simultaneously there's a trial going on now in China. It's a coronavirus vaccine. It's called AD5-nCoV. The University of Oxford's Jenner Institute, Oxford Vaccine Group, they've also started developing a COVID-19 vaccine that was taken from chimpanzees in January. However, there's only a 50% chance of the Oxford vaccine working because cases in the UK are declining so fast, they may not have enough people to test it on. You see, these are some of the real problems. Then some scientists are now suggesting we have a human challenge trial, which raises, of course, several ethical questions to speed up the vaccine clinical trials. Right now, there are more than 16,000 people in over 100 countries who have signed up to take part, but it needs some ethical clearance. WHO is working on that. We don't know, but it's going to be a human challenge trial. So, you know, the problem is we are all looking at the vaccine as that single magic bullet that would help the world put an end to this, vaccine. But you see, there's also this picture which shows you how quickly can we develop a COVID vaccine at speed. You know, we have the discovery research stage, which is a few months, the preclinical stage, then we have the regulatory review and approval, 3 months for one vaccine, 12 to 18 months, and it costs at least $3 billion to produce a vaccine. Yeah. But anyhow, the good thing is with COVID-19, we have seen technological leaps in infectious disease interventions. You know, for smallpox, it took us almost 3,300 years to get a vaccine. Polio, even longer, 3,348. Cholera took us 2,345. Measles, 14-17 years. Rubella, 352 years. HIV/AIDS, 15 years. Ebola, 5 years. COVID-19 human trials have been taken up within 4 months of the disease starting. So there is hope, but I don't want to say it's a 100% guarantee that we'll succeed. You know, people are investing billions of dollars in vaccine trials. As I said, there are so many trials going on right now. So let's hope one of the vaccines works. That'll be great for the world.
Sure. There's one question, you know, about Kerala as being the star amongst the Indian states, and it's been being taught all over the world, I'm told. So would you comment to that? And also there's a question about, is WHO really at fault for not having notified the world about this pandemic sooner than it did? Two questions.
Yeah. Okay. So Kerala, of course, I think I also mentioned that initial data has also shown that, you know, one of the first cases in India actually happened in Kerala. Yeah. It's a student, I think, who returned from Wuhan, if I remember right. And the first few cases in India were actually in Kerala. So, but, you know, Kerala was very quick, you know, their social community system, their community awareness, you know, the contact tracing, the amount of testing that has been done in Kerala. I think it's a great model for the rest of the country to emulate. And I think they had a very dynamic health minister, you know, who has actually been praised even by the government at the center for leading the way. You know, she was in the forefront in Kerala. So Kerala, I think their strategies were multifaceted. You know, It was a multi-pronged strategy that worked. And people's complaints, you see, after all, Kerala has always been ahead in health situation in the country. Kerala has disproved this theory that, if your socio-economic status is good, your health status is good. No, not necessarily. What they have shown time and again in all fields, it's one of the first states in India to have 100% immunization coverage, So way back, and it's Kerala's success is not today's, it's a cumulative success over the years, not necessarily because of the government today, but whichever government has been there, it's the community support. I think that's largely responsible for Kerala's success. Your other question was about WHO. WHO has this international health regulations which they could have exercised and declared a pandemic sooner than in March. They should not have waited until March to declare. They let uh, thousands of people from Wuhan go out all over the world, and Wuhan to Italy, Italy to India, Italy to the US, and Wuhan to US. So you have seen how the spreading has occurred. In the previous epidemic, SARS epidemic or MERS or whatever, WHO played really a stellar role. If those pandemics were not, you didn't hear of these huge lockdowns during those pandemics, right? Because those days they were quick to intercept, quick to announce the pandemic. And I think this is the time where I think, more than 3-4 months, the delay that has occurred has really costed the world. It's costed us billions of dollars. And it's not just billions, but, millions of, hundreds of thousands of people affected, millions of people affected socioeconomically. I will pause here.
There are some questions revolving around, is it safe to go out and eat, and, we are getting close to 7:30.
Yeah.
To answer this question, what I would do is invite Ravi from Florida and Mr. Gopalakrishna, who's been the health secretary in the union government, to give two different perspectives. So could you answer, Seshu, about is it safe to go out and eat during this time?
Is it safe to go out?
And eat outside in restaurants, hotels?
Oh, I would strongly advocate not going out to eat. You may bring a takeaway home, take all the precautions, with the food package, and consume it at home. I don't think we are in a stage where you can actually maintain social distance in restaurants and, make sure that, the proper clothing, masks are worn by, the serving staff and so on. So, particularly the way the epidemic is moving in India, I think we have to be extremely cautious. Personally, I would not go out. I might bring food home, but not really dine in a hotel. I think we have to forget that for a few more months, not even weeks.
Thanks, Seshu. May I invite Mr. Gopalakrishna? I'll unmute you. You've been a senior bureaucrat, former chief secretary. You've worked in the Northeast in different states. You've also in the health portfolio. What is your take on the way the government in India is tackling this pandemic?
I think India had to actually tackle this pandemic knowing fully well that if it were to spread very fast, it would be very difficult to provide them all the assistance required. Particularly, the infrastructure in the health sector is not adequate to actually do that much of testing that was required, and also to be able to actually provide proper accommodation and treatment for all this. That is why I think we have actually accepted whatever was a realistic way. I only wish that if, in the light of what had happened in other countries, WHO could have actually taken a more active role to advise India about what should have been done in time. For example, the migrants issue that we have now having, and people who had to be unnecessarily put to great trouble, and particularly our uh, inadequacies which came up in the process. These were some of the things which I think could have been avoided, but India seems to have done the best as far as the recovery rate is concerned, and also less number of deaths. Maybe we are having more internal immunity which is protecting us, and maybe because of the sun also, maybe it might have helped. But I think it is better that we are cautious for some more time to come. Otherwise, our economy will also be very badly affected.
Thank you. Thank you. May I invite Dr. Ravi Ramaswamy, who is a physician in Florida right now. Ravi, one of the questions is, the health infrastructure in US is considered the best in the world, or one of the best in the world. And one of the participants is asking, how come US has such a widespread infection and they're struggling to control it in terms of deaths? Could you comment on that? I'll unmute you.
Yeah. Thank you, Subha. So before that, just a couple of things I wanted to say about one thing about what Seshu said. Seshu, excellent talk, by the way, is about Kerala. You know, one of the other things that goes in favor of Kerala is their high literacy rate, and I kind of wonder whether that also had something to do with this. And the second thing was about the vaccine, and I'll get to your question, Subha. The vaccine, as Seshu said, the flu vaccine is given every year in the US, but we are always 1 year behind. We learn from this year's virus to go to next year's flu vaccine. So in the terms of the coronavirus, it's not quite clear if this virus mutates, if there's going to be more strains coming next year. So even if a virus vaccine is formulated, it may not be 100% protection, and we'll have to see what goes on. Now, coming back to your question about the infrastructure in the USA and why they have so many cases, the first thing, of course, is denial is not a river in Egypt. So there was a lot of denial in the early stages, not just from the president, but also from the health authorities, the CDC, the National Institute of Health, Dr. Fauci, who is the poster child of this pandemic, even as late as March said, you don't have to wear masks. So the way they approached it, as opposed to what happened even in Kerala, is the fact that they did not say, okay, this is a serious problem and we need to contain it. And even when the president banned travel from China in March, he was called a racist and a xenophobe, etc. So there's a societal influence also. People, as you know, must have read in the news, people are are refusing to wear masks. They are going to the beaches. They're not really social distancing themselves. So a lot of these socio as well as socioeconomic situations came into play. Now, it's not entirely true that the USA has, I mean, it does have a large quantity of cases and, of course, over 100,000 deaths. But a lot of these ventilators are now unused. Now, I'm from Florida, a sunny state, and as someone just mentioned, the sun may have something to do with it. But in Florida, about 6,000 ventilators have not been used. All the temporary hospitals, makeshift hospitals have been dismantled. In the hospital locally, we only have about 7 people on ventilators from the COVID virus. The number of admissions has only been about 7%. We are also going to phase 2 of the recovery program. The question is that there is an issue of panic versus reality versus the pandemic. And a lot of these things, the models, there was a great degree of inaccuracy. The played a big role in the panicking aspect of it. And after a while, the threshold becomes so overwhelming. Like 9/11, when 3,000 people were killed, it was a big shocker. Now, when 100,000 people die, we kind of get numb and insensitive to it. And we say, hey, let's not do this, or let's not wear a mask. It's not the flu, kill more people. A lot of these denial issues come into play. So I think that was one of the reasons why the virus spread like it did. But on the bright side, a lot of states are recovering. Like over here, the gyms are open, the hair salons are open. We can actually go out to eat, and they are doing the social distancing. But the mask is here to stay. The physical distancing is here to stay. The disinfectants are here to stay. So a lot of social issues are going to be altered. But there are a lot of cases for the reasons I mentioned, but it's really not as bad as it was predicted to be. And I think part of it is based on the fact that in states that followed the distancing and the masking and the quarantining, things worked much better. Like Dr. Seshu said, in the start of the pandemic, that is very important. But of course, everybody pays an economic price. And so indefinite lockdown or extended lockdown is actually going to be more of a problem than the pandemic itself, because it's okay to be alive. Every life is precious. We cannot have more people die. But are you going to die of starvation? Are you going to die of not putting food on the table? Because eventually that is going to be a factor. There's going to be about 7,500 people with drug abuse, alcoholism, and suicides predicted right in the US because of the lockdown. So it can work both ways. But yes, there have been more cases here for all the reasons I mentioned. But on the other hand, things are not as bad as they were supposed to get.
Thanks, Ravi. I just want to wrap up before I invite our secretary to propose a vote of thanks. Some questions we could not take, obviously, for lack of time. I want to announce that Dr. Seshu has been gracious to allow us to share his slides. In fact, he sent me a second set, which are far more detailed. So I will share them with you. It's a large file. So I will share a Google link and you should be able to get it.
I wish to add 2 points if you allow me.
Yeah, just 1 minute, Aurora. And the second thing is...
First point is...
One moment, Dr. Aurora. One moment. One moment.
A lot of people are...
Dr. Aurora, can you hold on 1 minute, please? Dr. Aurora, can you hold on? Yeah. We had decided to hold our meetings via video conferencing till June when we last decided. Now, post 31st, we'll know what the situation is about the lockdown or changes. The executive committee will take a call, given that all our members are senior citizens, whether we should continue with this for some more time. We have also heard Dr. Seshu tell us it's not back to normal. There's a new normal we need to kind of think of. So we will get back to you on how our June meeting will be a video conference for sure. But as far as the subsequent meetings, we'll get back to you. So before the vote of thanks, I invite Dr. Arora, who heads Apollo Life. He has a couple of points. Go ahead, Dr. Arora.
Thanks a lot. There is one pertinent point for every Indian citizen. People are using masks. They are using gloves. They are not destroying them by cutting, but they're throwing in openly. Other day we saw the waste collector children were collecting those for recycling purpose. Second point, which is a very pertinent point, you must have all noticed in the news, Indian and Chinese soldiers are grappling with each other on the eastern part of North Ladakh. In my perception, since I have spent almost 40 years with the armed forces, Chinese attitude we know. It is possible all carriers Chinese soldier have been put there because none of them were wearing mask, neither Indians nor Chinese. They may transmit this infection to those soldiers, and we suddenly find a huge soldiers falling sick. So this is the two aspect of the point which need to be conveyed to every citizen. But the attitude of Chinese we cannot trust, and that is a high possibility. We need to think about it. And third is we need to be prepared now. Corona emerging from villages where all these migrant laborers have reached back because our industry did not learn the lesson from Second World War. All the industries were running despite bombardment. They never sent their workers back to their homes. And that's what we are going to face it. The second spurt will come from villages. There are no facilities, no hospital, no shops, no caretakers. So that will be a very unusual thing which will take place. The governments need to think very seriously on that aspect. Thank you.
Thank you, Dr. Arora. Very valid points. We had just before we invite our secretary to propose a vote of thanks. Seshu, there were about 75 people. You know, off and on, there were numbers are changing. Right now, we are about 54. So shows the attractiveness of the topic on which you spoke. Thank you for that. May I invite our secretary, Mr. Bose, to propose a vote of thanks, please? Yeah, we can hear you.
Hello.
Yes, we can hear you. Please go ahead.
Are you able to hear me?
Yes.
I, on behalf of FOSWL India Hyderabad, thank all the 70 plus participants who joined this Zoom meeting from across the globe in these days of pandemic. We are especially happy that several guests have also joined us from several cities and countries. We thank the family members of Sri Tipineni Venkateswara Garu for establishing an annual endowment lecture in his name. We also thank Sri Bindu Madhav Yuvaturi for sponsoring the logistic support for this month. It was a pleasure and very educative to listen to Dr. Seshu Babu Vinjamuri. It's an excellent talk on pandemics, the past, present and future. We learned of how pandemics, the worldwide spread of new diseases, are a part of human history. Dr. Seshu Babu's talk threw light on at least about 20 well-documented pandemics that afflicted humanity over the years. His talk had also revived our memories of the more recent epidemics or diseases like the MERS, Zika, SARS, H1N1, Ebola, swine flu and AIDS, apart from others. Thank you, Dr. Seshu Babu, for fielding our questions with such clarity and patience. We especially thank you for the considerable effort that has gone into in the preparation of the slides. I also wish to thank Dr. Saivya Chaudhary Tipineni for sharing her experiences as the grandchild of Sri Venkateswara Garu and giving us a glimpse of his life and work. As some of you may be aware, Dr. Saivya has offered free video consulting for any FOSWL member and their families during this lockdown. We are happy that some of you have availed the offer. We are happy that Kaustubh, Sri Venkateswara Garu's grandson, would also join this meeting from New Jersey. I must thank Sri Jayant Satay for introducing the distinguished speaker for today. I wish to particularly thank the schoolmates of the speaker and some of his professional colleagues for joining us today. As you are all aware, FOSWL has completed 11 years since its inception in 2009. In all these 11 years, not a single monthly meeting was missed till the recent 135th monthly meeting due in March 2020 due to lockdown announced by the Government of India. I am happy that we could arrange this special meeting in lieu of that missed meeting over Zoom today. FOSWL meets on the third Saturdays of each month. Since March 2020, we have been meeting on Zoom conferences. Till the situation permits us to meet physically again, we propose to meet on such virtual meetings. I invite all our guests who are with us today to join us for these very interesting monthly talks that FOSWL Hyderabad arranges. We had decided that FOSWL will hold only virtual meetings till the next month, that is June 2020. The executive committee will review the situation in due course, and we will notify all the members of the plan for July onwards. Once again, it was great to meet all of you this evening. Wish you all a good and safe weekend. Good night, ladies and gentlemen. Thank you all.
Subala, can I share?
So Sannyasi Rao, the speaker has agreed to share his slides with you, not for you to publish. Please don't do that.
Okay. So
we'll talk offline. Yeah. So guys, everybody, thank you all for joining. It was a great meeting. And Seshu, thank you again. It was very nice to have you join. I know it's very late for you in Cambodia. And Rajendra, Ravi, Nitin and all, I'm sure it is a little too early for you on a Saturday morning. But it was good that all of you could join. So good night, and I'll sign off now. I'll exit the meeting.
HPS guys, can we stay on for 5-10 minutes? HPS.
Yeah. So HPS guys, if you want to stay on for 5-10 minutes, please stay on. Or I can just set up another meeting immediately, Ganga.
Title Subbu, maybe that. Yeah.
I close this meeting. I'll just
unless Ravi is busy with this.
Yeah, I'll just put the new link on our WhatsApp group.
Can I talk to
Subha?
Yeah.
Can you copy everything in the chat box? I'm not able to do it at my end.
Okay. Actually, I have sent it. I have typed and sent to you.
Subhash. I will send you, Subhash. I will send you.
Okay.
I will send you personally through WhatsApp. And if you can give me your email, I will email you some good stuff.
Okay.
Through WhatsApp, you just give me
I will send my email on the WhatsApp.
Huh? Yeah. Then I will send you. All right, Subhash.
I just wanted your guidelines for clinical purpose, general practice.
Yeah. I will send you. Okay.
Thank you.
Wonderful. Thank you so much, Subhash.
I'm ending this meeting for the HPS guys. I'll just post the link right away. Bye-bye.